Hello, future doctors. How are you all? Welcome back to MedSteps Internal Medicine Series, Episode 6 by Dr. Anand Jana. So, in today's episode, we are going to discuss one of the most important topic in internal medicine, that is heart failure. So, heart failure is one of the most commonest causes of hospital admission worldwide. It does not mean the heart has stopped working. Instead, it means the heart can't pump enough blood to meet the body's needs, or can do so only with increased filling pressures. So today we will cover definition of heart failure, pathophysiology, and we have different classification and what are the cause heart failure and clinical features, diagnosis, investigation, how to do management, acute and chronic heart failure, and some exam point of view, high yield points and clinical cases we are going to discuss in this video. What it means, what is heart failure? If you are saying here, heart failure is the inability of the heart to provide adequate circulation at normal filling pressures to meet the body's metabolic demands. It's caused structural or functional abnormalities of the heart. So, in simple, heart failure is a clinical syndrome caused by structural or functional abnormalities of the heart, resulting in reduced cardiac output and elevated intracardiac filling pressures and leading to inadequate tissue perfusion and congestion. So, whenever any doctor is asking about heart failure, in simple language you can tell like the heart becomes too weak or too stiff to pump blood efficiently. Okay, so this is the main thing. So if you are seeing normal heart function, the normal heart we can see it will the normal sequence if you're seeing means the body will get venous return from right heart, then after it will go to lungs, then after left heart, then after aorta, then after body. So this healthy heart pumps approximately around 5 liters per minute at rest. When pumping ability decreases, the cardiac output will reduces. So the body organs receive less oxygen and the kidney will retain and sodium and water and the blood volume will increases. Then after the heart works even harder and the symptoms will become worse. Okay, so this is the things. Next you can see here we have two different types of classification of heart failure. So first of all, we can divide this classification into different methods. First of all, you can see here that is based on ejection fraction. So in ejection fraction, we can see here that is we can see based on systolic versus diastolic heart failure. We have two different types of heart failure. So first of all, you can see here that is systolic heart failure or heart failure with impaired ejection fraction. So in systolic heart failure we can see it's like inability to ventricles. Systolic means it's related to contraction. Okay, so inability to contract properly resulting in reduced cardiac output, then the ejection fraction will reduce less than 40%. So why it's causing like this? Because of ischemic heart diseases and cardiomyopathy. What will happen here? Whenever patient have ischemic heart disease or history of ischemic heart disease or cardiomyopathy, the cardiac cells will die. Whenever the cardiac cells will die, then it will lead to systolic heart failure. Okay, next you can see here that is diastolic heart failure. In diastolic heart failure or heart failure with preserved ejection fraction, it's like inability to ventricles relax. So diastolic means always it's related to relaxation problem. So therefore fill adequately and ejection fraction greater than 40% you can see, and that causes include cardiac tamponade or constrictive pericarditis and restrictive cardiomyopathy. Here what happening, for example, this is pericardium. Inside the pericardium you can see heart like this. Okay, so here what happen, if any patient have inflammation in this pericardial layer or cardiac tamponade, here if any fluid filled blood filled means then we call that is cardiac tamponade. If this pericardium become inflamed, we call constrictive pericarditis. So restrictive cardiomyopathy. So these are the things will cause diastolic heart failure. So next classification will be like we can divide the um, heart failure into left and right heart failure. In left heart failure, or ventricular failure may occurs independently or together as congestive cardiac failure. So in heart failure, we can see in left heart failure, you can see the blood will backs into the lungs. So the patient will get symptoms like dyspnea, difficulty in breathing, orthopnea. Whenever they are lying, they will get breathing problem. Whenever they are using two pillows and they are coming to semi-fibular position, they are not going to get any pain. And paroxysmal nocturnal dyspnea means suddenly they will get difficulty problem without knowing at night time. And pulmonary edema in lungs, we can see some fluid will fill, then after cough, this everything will comes in left heart failure. Next we can see right heart failure, like blood backs into the systemic veins. So the symptoms you can see like pedal edema and raised jugular venous pressure and ascites and hepatomegaly and abdominal swelling. And we can see biventricular failure, it's like combination both different both like left heart failure and right heart failure symptoms we can see, then we call that is biventricular failure. Next you can see here that is acute heart failure versus chronic heart failure. In acute heart failure, it results from sudden failure to maintain cardiac output and there is insufficient time for compensation mechanism to develop. So that is we call acute heart failure. Next you can see that is chronic heart failure. In chronic heart failure you can see that is cardiac output declines gradually. The symptoms related to compensatory mechanisms and predominating. Okay, so that is acute versus chronic heart failure. Next you can see about reduced ejection fraction. So here you can see low output heart failure versus high output heart failure. So in low output heart failure, we can see the cardiac output is decreased and unable to meet the demands of the body. Next you can see that is high output heart failure. In high output heart failure you can see like it will be like rare and output is normal, and we can see increased in the face of increased needs, example like Paget's disease, hyperthyroidism and anemia. Okay, so these are the things we can see here. So next you can see that is pathophysiology. In pathophysiology, this is very important, the pathophysiology. So based on pathophysiology, while discussing, we will discuss why people will get the symptoms about heart attack and everything. Okay, so in healthy heart, the heart pumps like around 5 liters per minute at rest, like that I told, right? So when pumping ability will decrease, then the cardiac output will decrease. Whenever the cardiac output will reducing, the body organs receives less oxygen and kidney will retain so sodium and water, and the blood volume will increase. The heart works even harder, then the symptoms will become worse. So in pathophysiology, if we are saying here, whenever this is the most important concept in heart failure. So if you are seeing heart muscle, normally in heart failure we can see injury of the myocardium from a variety of causes. We have some causes like myocardial infection or hypertension or valve disease or cardiomyopathy. These are the main causes will cause heart muscle becomes damaged. Whenever the heart muscle becomes damaged, we can see contractility. So the contractility will decrease, then after we can see the stroke volume will decreases, then after we can see the cardiac output will decreases. So here what will happen, if you are seeing here, the cardiac output will reduce, the contractility will decreases, then after the stroke volume will decreases, the cardiac output will decreases. Why? Because the heart failed, then after several compensatory mechanisms will activate and it will occurs as the failing heart attempts to maintain adequate function. So we have in the cardiac output will try to increase, so in the compensation method mechanism. So next you can see the body will compensate. How? The brain senses will reduced perfusion. So what will happen whenever the cardiac output will reduce? You can see here what the brain will do. It will activate nervous system, and we can see sympathetic nervous system and RAS activation. In sympathetic activation, what will happen? The body will compensate, the brain senses reduces perfusion, so the sympathetic activation is activated. Okay, so here what will happen? The heart rate will increase, the contractility will increase. So whenever the heart rate and contractility increased, then after the peripheral vasoconstriction we can see, then after it will initially it will helpful, then after long term will be like harmful. Okay, so this is the thing. So next another mechanism we can see, that is the reduced cardiac output will activate RAS activation. What it means? RAS is one type of we call renin-angiotensin aldosterone system. This is the main RAS activation the kidney will detect. So the kidney will detect low blood flow, and the kidneys will detect low blood flow, and the renin will released. So it's related to kidneys. Okay, the kidney will detect low blood flow, then after the renin will release, then after you can see angiotensin 2 will release, then after vasoconstriction will happen, then after aldosterone secretion, then after sodium will becomes retention and water retention. So this sodium and water retention we can see, then after the blood volume will increases, then after the preload, whenever we can see vasoconstriction, the increasing after load, then after the increasing preload. Okay, then after we can see pulmonary congestion, and then because of that thing we can see peripheral edema. Okay, next here we can see the heart rate will contractility, the increased cardiac workload, then after cardiac direct cardiotoxicity, myocyte will become damaged. So the cardiac remodeling, persistent overload causes like ventricular dilation and hypertrophy, and it will lead to fibrosis. Then after at last the patient will get progressive heart failure. So in early stages, this sympathetic nervous system activation and RAS activation will helpful to compensation mechanism of the heart, but when it's becoming long term it will become worsening. Okay, so this is the main things of pathophysiology of the heart failure. So next you can see here causes of heart failure. The causes, first of all, it will be like myocardial diseases like coronary artery disease, CAD. If you didn't watch about coronary artery disease, in that episode 5 we already discussed about coronary artery disease. If you didn't watch, please go and watch, so you will get one idea. And hypertension, then after cardiomyopathies. Next we can see valvular heart diseases like aortic stenosis, arrhythmias like atrial fibrillation and other arrhythmias, and pericardial disease like pericardial effusion, constrictive pericarditis and cardiac tamponade. Next you can see that is congenital heart diseases like atrial septal defect and ventricular septal defect, and high output states like anemia, thyrotoxicosis, liver failure and Paget's disease and beriberi. And you can see that is drugs like alcohol, steroids, chemotherapy and NSAIDs. And severe lung diseases we can see example like COPD, obstructive sleep apnea and pulmonary embolism. So these are the main causes we can see in heart failure. Okay, so next we can see here that is clinical features. Next we can see that is clinical features. Clinical features. Actually first we have to divide heart failure into two different types of causes. One is heart failure reduced ejection fraction. Heart failure reduced ejection fraction. And another one we have heart failure preserved ejection fraction. So in heart failure reduced ejection fraction you can say coronary artery disease, myocardial infarction, dilated cardiomyopathy and myocarditis and severe valve disease. In heart failure, preserved ejection fraction, we can see like long-standing hypertension, diabetes, obesity, elderly and restrictive cardiomyopathy, and other causes like arrhythmias, congenital heart disease, and thyroid disease like alcohol and chemotherapy, and pregnancy like peripartum cardiomyopathy. So next we can see here that is clinical features of the heart. First we can see symptoms here. In symptoms, we can see the most common symptom will be like dyspnea, shortness of breath, initially during exercise. In later at rest also patient will get a breathing problem. Other symptoms we have that is like fatigue and edema and nocturnal cough, and we can see with or pink frothy sputum we can see, and patient will get some wheezing. Then after orthopnea, then after paroxysmal nocturnal dyspnea we can see PND. Then after cough, then after we can see nocturia. In night time they will pass more amount of urine, and cold peripheries because of reduced perfusion. Then after we can see weight loss and muscle wasting. Okay, weight loss and muscle wasting we can see. Okay, so here we can see some signs. In signs we have like in vitals way. In general, if you're saying means the patient will get tachycardia, tachypnea, and cyanosis. In neck, we can see that is okay. We can divide into two different types of pathological conditions. First one, left heart failure, displaced apex beat. So we can listen apex beat. Okay, then after gallop rhythm, third heart rhythm we can see. So that is S3 gallop or murmurs we can call. Inspiratory crackles and wheezing we can see. So left heart failure means everything related to lungs. Then after we can see pitting edema. What it means? In peripheral extremities you can see pitting edema like this. Okay, if you are pressing means you can see the depression in lower limbs, we call that is pitting edema. Okay, so next you can see here that is right heart failure. Signs of right heart failure. One is raised jugular venous pressure. So the JVP will increase. If you're seeing here, this is neck. In this neck, the external jugular vein is passing like this. So here what will happen? So this is the clavicular line, and this is the sternocleidomastoid muscle. We can see it will go like this. Okay, so this is sternocleidomastoid muscle. It will insert to the mastoid process. So here you can see that is external jugular vein. So the external jugular vein will, we can see distension. Okay, that means right heart failure. So if you are seeing JVP raised, so we have to suspect right heart failure, and we can see hepatic enlargement. The hepatoreflex also will increase. Then after ascites and pitting edema we can see in right heart failure. In lungs, in left heart failure we can see bibasal crepitations. Okay, so these are the things. Next we can see here that is staging of severity. How we have to follow the how we have to do that severity staging means we have one score we call NYHA, means New York Heart Association classification. In New York Heart Association classification is used to stage of heart failure according to the based on symptoms. So first one, class 1. In class 1 we can see no limitations and no symptoms. Okay, so ordinary physical activity but no symptoms. So that is class 1. But you can see some symptoms like swelling, a raised JVP. This type of symptoms you can, this type of signs you can see, but no symptoms. Next, class 2. In class 2, we can see symptoms during ordinary activity. So symptomatic but mild, slight, you can see that is also physical activity, and ordinary symptoms during ordinary activity we can see. Next, class 3. In class 3 we can see that is patient will get symptoms during minimal activity. If they are doing minimal activity also, it will cause symptoms. So that is class 3. Next, class 4, the patient will get symptoms when they are taking rest also. So that's why we call that is symptoms at rest. So that is class 4. So now we are going to do in simple way. We have New York Health Association classification. In class 1, no symptoms. Class 2, symptoms during ordinary activity. In class 3, symptoms during minimal activity. Symptoms in class 4, we can say symptoms at rest also. Okay, now how to diagnose? Whenever patient have heart failure, we can go with first of all we have to go with history, then after physical examination or clinical examination, then after we have to go with investigation. Okay, so this is the main diagnosing steps. So first we can go with investigation. In investigation, first of all we have to check we have to do some blood workup, like full blood count and urinary analysis, liver function test, thyroid function test, lipid profile, and another one BNP, means B type natriuretic peptide, and NT pro BNP means N terminal pro beta natriuretic peptide. Okay, so here it's released when ventricles are stretched. Okay, when ventricles are stretched and high valve supports heart failure and low valve makes heart failure unlikely. Okay, so next you can do urinary analysis for checking nephrotic syndrome present with fluid overload. Next we can do chest x-ray. In chest x-ray we have to follow A, B, C, D. Okay, in A we can see alveolar edema, and B means curly B lines, C means you can see cardiomegaly, D means dilated upper lobe vessels, and P means pleural effusion. So these are the main 5 things you can see in chest x-ray, like A, B, C, D, E. A means alveolar edema, B means curly B lines, and C means cardiomegaly, and D means dilated upper lobe vessels, and E means pleural effusion. So next you can see here that is ECG. This ECG may show like previous myocardial infarction and atrial fibrillation, and it will show left ventricular hypertrophy and previous and arrhythmias and previous MI. So next we can do that is echo test. Echocardiography is the gold standard for helping to it will help to show ejection fraction, valve diseases like my history. Valve is working or not, and and it will confirm the presence of patient have systolic or diastolic heart failure, like reduced ejection fraction or preserved ejection fraction or mid-range ejection fraction. Based on echocardiography, it will show some main thing is ejection fraction, and it will help to identify the valve diseases and chamber size and valve motion abnormalities and diastolic dysfunction. Okay, so next we can see some lung function test to rule out respiratory diseases. On cardiac MRI, it's gold standard for ventricular volumes and mass and valve motion, and it can also be used to identify inflammation, infiltration, and scarring of the myocardium. So this is the main investigation. Okay, so next you can see here, this is the X-ray. In X-ray you can see this type of structures. One is alveolar edema, means bat wing signs. Why alveolar edema? Because whenever patient have heart failure, they will get pulmonary edema. So this pulmonary edema will cause bat wing appearance. Okay, next we can see curly B lines. This curly bean lines because of interstitial edema. Next we can see the costophrenic angle will become blunt because of pleural effusion. Next we can see the blood vessels. The upper lobe blood vessels will become prominent. So you can see this type of blood vessel structures. Next the heart size will increase, so that's why we call that is cardiomegaly. Next we can see here that is management. So management. So in heart failure we can divide into 2 different types of management. First one, we have to the management. In management, first we have to focus on reducing the main goals will be like to improve symptoms and to prevent progression, and it will help, and we have to reduce the mortality, and we have to improve the quality of life. Okay, so first of all, in management we can see that acute heart failure and chronic heart failure. In acute heart failure we can see sit patient up. Always patient must be on Fowler or semi-Fowler position. If you're keeping flat in supine position, the patient will get orthopnea or difficulty in breathing. Okay, so that's why the sit patient up. Then after high flow oxygen, because they are going to get breathing problem. Okay, and in lifestyle modification you can see fluid restriction like selected patients, and weight reduction, and exercise we have to encourage. Smoking cessation, if alcohol means alcohol drink consumption means, so the patient have to quit smoking and alcohol, and vaccination properly, and daily weight monitoring we have to do, and medication we have to use properly. So here we can use intravenous furosemide, example like 40 milligram. Intravenous we have to go with bolus. Next, another one we can give diamorphine for chest pain. If patient getting pain, example like 2.5 to 5 milligram we have to give. Okay. Next we can see that is if blood pressure is stable greater than 100 systolic we have to give, and we have to consider GTN spray 2 puffs sublingually if patient getting any problem with heart attack. Next we have to do catheterization to monitor urine output carefully. Next we have to treat underlying cause like myocardial infarction, arrhythmias. If patient getting too much breathing problem, we have to go with CPAP in heart failure patient. Then after blood pressure, if blood pressure is low, less than 100 systolic, and we have to consider ITU, and we have in admission time inotropes, and example like intravenous dobutamine for treatment of cardiogenic shock. So next you can see here that is chronic heart failure. In chronic heart failure, we have to stop any offending drugs if possible, such as like NSAIDs, calcium channel blockers, and example like verapamil, and smoking cessation as we discussed before, and the diet and fluid intake, diet we have to give, and alcohol and exercise and traveling we have to. The patient is like NYHA class 1, class 2 means they can travel. In class 3, oxygen is required. Okay, in class 4 they can't travel properly. And sexual health, no specific restrictions for sexual activity but slight risk of decompensation with NYHA 3 and 4. Okay, so patient will get sexual dysfunction is common in heart failure patients. Okay, due to condition of because of using medication, side effects of the treatment. And mental health and well-being, depression is very common in heart failure, so we have to screen and managing we have to accordingly. Immunization is very important, annual influenza vaccination, because they are very prone to get single pneumococcal vaccination is the best thing, because they are very prone to get pleural edema, pulmonary edema, and pleural effusion, respiratory related problems. Next, pharmacological management, we have to reduce some drugs to reduce mortality like ACE inhibitors and angiotensin receptor blockers. We have to reduce it, the drugs will reduce the mortality. Okay, so next we can see here that is some medication. First of all, ACE inhibitors. The ACE inhibitors will reduces RAS activation, example like enalapril and ramipril. Okay, so I will say this notes, you can read this thing, because the ACE inhibitors is the main thing to, it will all patients with the left ventricular ejection fraction less than equal to 40%, regardless of symptom severity, should receive ACE inhibitors. If patient have left ventricular ejection fraction is less than 40 means the patient have to receive this ACE inhibitors, because this ACE inhibitors will help to improve ventricular function and patient well-being and reduce mortality. and it will start at low dose and titrate upwards at short intervals. Example like every 2 weeks until target or maximum tolerated dose reached. So we can see these ACE inhibitors have some side effects like dry cough because of bradykinin, and it will cause angioedema, hyperkalemia, and hypotension. Okay, so this is ACE inhibitors. With the first line drug, we are going to give ACE inhibitors. Along with that, we can give ARNI. ARNI means we have some drugs we called sacubitril and valsartan. Okay, so this sacubitril we called you have to give sacubitril and valsartan. The sacubitril is prodrug. It will inhibit to breakdown of natriuretic peptides, and it will resulting in varied effects including increased diuresis, natriuresis, and vasodilation. And the main indications of include like symptomatic chronic heart failure with ejection fraction less than 35%, and patients not currently taking an ACE inhibitors or ARB and stabilized on low doses of either of these agents. Okay, so ACE inhibitors and ARNI is very best combination and drugs. Okay, next we can see that is beta blockers. In beta blockers we can see like it will reduce sympathetic overactivity. So whenever in beta blockers we can see like bisoprolol and nebivolol and carvedilol. So these are the main drugs you can see in beta blockers. Like this, in beta blockers we can see should be like used in all patients with symptomatic heart failure and left ventricular ejection fraction we can see less than equal to 40%, where the tolerated and not contraindicated. The main common side effects we can see bronchospasm and fatigue and cold peripheries and sleep disturbance we can see in beta blockers. And asthma and second and third degree heart block means we have to do sick sinus syndrome we call without a pacemaker, and sinus bradycardia are contraindications to the beta blocker use. Okay, if patient have asthma at second and third degree heart block, sick sinus syndrome without pacemaker, and sinus bradycardia like less than 50 beats per minute means we can't give any beta blockers. And metoprolol succinate, right now in GPHC we are using this drug. So next we can see that is mineralocorticoid aldosterone receptor antagonist, like example spironolactone and eplerenone. This spironolactone and eplerenone we can see it relative weak diuretics with potassium sparing action. If patient have more amount of potassium like more than 5.5, we can't prescribe spironolactone. Okay, so in spironolactone is example like 25 milligram, it will reduces mortality in patients with heart failure with impaired ejection fraction, and eplerenone will reduce mortality in patients with acute myocardial infarction and heart failure. So patient will get gynecomastia, that is the most common side effect of spironolactone. The main contraindication is hyperkalemia. Next you can see that is SGLT drugs. Next we can see that is SGLT2 drugs, that is we called dapagliflozin and empagliflozin. That is the main drug will help to maintain. Okay, so yeah, dapagliflozin and empagliflozin, it will reduce hospitalization and mortality even in patients without diabetes. We have to use SGLT2. Okay, in additions based on symptoms we have, if it's indicating, we have to use the drugs like vasodilators. Vasodilators means we have to think like nitrates. Isosorbate mononitrate is a combination with hydrogen, reduces. Okay, isosorbate mononitrate will reduce preload and hydrogen will reduce afterload. So we have to use this combination drug. It will improve symptoms and survival in patients with systolic heart failure. Okay, so if patient have systolic heart failure, we can use isosorbate mononitrate for reducing preload and hydralazine for reducing afterload. So, and it should be considered in patients who are intolerant to ACE inhibitors or ARBs. Next, we can see here that is loop diuretics. In diuretics, we can see first of all loop diuretics, that is example furosemide 40 milligram we have to give orally, intravenous bolus or infusion, and bumetanide 1 milligram orally we have to give. So thiazide diuretics example like benro, flumethazide and endopamide are mild diuretics, and the exception is metalozone, which causes profound diuresis and is only used for severe and resistant cases by specialists. Spironolactone and eplerenone are relatively weak diuretics with potassium sparing action. Okay, so next we can see here that is ivabradine. This ivabradine should be like considered patients remains like symptomatic despite already on suitable therapy like ACE inhibitor, beta blocker, and aldosterone antagonist. It will it's like we have to use selected patients with elevated heart rate. Okay, because greater than 75 beats per minute and your left ventricular ejection fraction is less than 35, we can use ivabradine. Okay, next one, last drug, that is digoxin. Digoxin is we are using for selected cases only, especially with the atrial fibrillation. So consider we have to add on treatment in patients with remain symptomatic despite above treatments, useful in patients who have a combination of atrial fibrillation and heart failure. Okay, so these are the main medications we have to use for heart failure. Okay, so next we can see here that is management. How to do that management of heart failure means, first of all we have to start with ACE inhibitors and beta blockers, or we can go with ARNI. Okay, so in chronic heart failure patient means we have to follow this steps we have to follow. So first of all, ACE inhibitors and beta blockers. ACE inhibitors like ramipridine 1.25 milligram OD and bisoprolol 1.25 milligram OD we have to use. If use of ARBs, if patient like intolerant to ACE inhibitors, we have to go with ARBs. Valsartan 80 milligram we have to give OD. We have to consider hydrolyzation with nitrates, example like isosorbate mononitrate with intolerance to ACE inhibitors. So here why these two drugs is important means, hydrolyzation and nitrates will reduce preload and hydrolyzation will reduce afterload. So both have to work together. Okay, next you can see once the patient getting ACE inhibitors and beta blockers is working, then we have to go with mineralocorticoid receptor antagonist like spironolactone 25 milligram OD or eplerenone 25 milligram OD. And next we can see digoxin, hydralazine with nitrates or cardiac resynchronization therapy, or ivabradine or sacubitril and with valsartan. We have to go based on the patient condition. Okay, so next we can see here that is natriuretic peptide. What it means, the B type natriuretic peptide will release in blood when ventricular myocardium getting stress. Okay, in physiological action, the BNP is to reduce systemic vascular resistance and central venous pressure as well as increase in natriuresis. So the net effect is a decreased in blood pressure and decrease in preload and afterload of the heart. So in the N-terminal prohormone of brain natriuretic peptide, you can see is prohormone with an N-terminal inactive protein, and that is cleaved from the molecule to release BNP. So the natriuretic peptide will raise levels of BNP, and NT-pro BNP are suggestive heart failure. So you can see here, and very high levels are associated with poor prognosis. that is like cutoff values for BNP and NT pro BNP. So in BNP we can say high levels like greater than 400 pg per ml, and the levels will raise levels we can say like 100 to 400 pg ml. In normal value you can say less than 100. If the NT pro BNP increased means the high level will be greater than 2000, the raised level will be like 400 to 2000, and the normal level will be like less than 400 to pg um, per ml. Okay, the BNP may also be lowered and raised by other factors. It's important to take this interpreting the results. Some patients we can see increased BNP levels, so always don't suspect a heart problem. We have some other conditions. Other factors also will increase BNP levels like left ventricular hypertrophy, ischemia, tachycardia, right ventricular overload, hypoxemia, including pulmonary embolism, glomerular filtration rate like less than 60 ml per minute, sepsis, chronic obstructive pulmonary disorder, and diabetes, and age like greater than 70 years, and liver cirrhosis. Next, decrease BNP levels you can say that is obesity, diuretics, ACE inhibitors, beta blockers, and angiotensin 2 receptor blocker, ARBs, and aldosterone antagonist. So these are the main drugs can cause decreases beta natriuretic peptide. Okay, so we have acute decompensated heart failure, that is like presentation, sudden breathlessness, and pulmonary edema and low oxygen saturation. The main management will be like we have to position the patient first upright, then after we have to give oxygen with hypoxemic, then after we have to give intravenous loop diuretics, then after we have to consider vasodilators if blood pressure allows. We have to treat precipitating causes like example myocardial infarction, arrhythmia, infection, and non-invasive ventilation may be needed in severe pulmonary edema. So we have some complications. The whenever patient getting heart failure, we have some complications like complications we can see here, that is okay, we have some complications like pulmonary edema, cardiogenic shock, arrhythmia, stroke, especially with atrial fibrillation, and kidney injury, and sudden cardiac death, and multi-organ dysfunction. So, if you are telling about prognosis, the prognosis is poor on the whole, with approximately like 50% of people with heart failure during within 4 years diagnosis, and the mortality rate is in the UK appears like improving. This is mainly down to pharmacological agents and designated heart failure multidisciplinary teams. So in exam point of view, the heart failure is a clinical syndrome, not a single disease. The echocardiography is the key test to assess ejection fraction and cardiac structures, and BNP and NT pro BNP helps to support the diagnosis. And we can see orthopnea in heart failure like breathlessness while lying flat, and PND paroxysmal nocturnal dyspnea, sudden nighttime breathlessness relieved by sitting up. Next we can see S3 gallop like commonly suggest volume overload in systolic heart failure. The four foundational drugs we have classes for heart failure, reduced ejection fraction like ACE inhibitors and ARNI like sacubitril and valsartan, and beta blockers, mineralocorticoids receptor antagonist, and SGLT inhibitor. Okay, so heart failure is one of the most frequently tested topics in MBBS and end rotation exams in internal medicine and FMGE, NEET PG. If you are understand its pathophysiology, clinical features, and evidence-based treatment, you will be able to manage many common clinical scenarios confidently. So in the next episode of the MedSteps internal medicine series, we are going to start our gastrointestinal pathological conditions in internal medicine series, because already I covered everything in cardiology, the most important high yield topics. Okay, so thank you for watching. If you found this video is helping you, like, share, and subscribe to our MedSteps medical education, and and keep learning one step at a time. Okay, so till that time, take care.